There are medications that can prevent fractures in postmenopausal women, and some of them can also reduce breast cancer recurrence. Understanding which drug, why, and for how long, and what risks to watch for is exactly what we're covering here today. There are two main classes of bone protective medications used in this setting: the bisphosphonates, which is an older, well established class available in both IV and oral forms, and denosumab, a newer monoclonal antibody given by injection. Both are classified as antiresorptive agents, meaning that they reduce bone breakdown, but they work through completely different mechanisms. Let's start with the bisphosphonates. How do they work? Bisphosphonates attach to the surface of the bone, and they are absorbed by the osteoclasts, that demolition crew we talked about, when those cells try to break down bone. Once they are inside the osteoclast, bisphosphonates disrupt critical enzyme pathways, causing that osteoclast to malfunction and undergo cell death. That's a process we call apoptosis. So, what's the net effect? The demolition crew is suppressed. Bone resorption slows down dramatically, and bone density is preserved or increased. The forms available are intravenous zoledronate, also called reclassed brand name, 4 milligrams IV every 6 months for bone protection in the cancer setting, or 5 milligrams IV for osteoporosis. This is the most studied and recommended for women on AIs. It also has proven anti-cancer benefits like reducing bone metastasis and improving survival in postmenopausal breast cancer patients. This is unique and very important. In the oral formulation, we have alendronate or Fosamax, 70 milligrams once a week, risedronate or Actonel, 35 milligrams also once a week, ibandronate or Boniva, 150 milligrams once a month, and clodronate, 1600 milligrams daily. What are the advantages of IV bisphosphonates? Well, compliance is ensured because it is given at a clinic visit. There are no GI absorption issues, and there are long-lasting effects even after stopping it. And there are also anti-cancer benefits with zoledronate, which I'm going to explain in a separate video. What are the disadvantages of the oral bisphosphonates? They must be taken on an empty stomach. You need to be sitting upright, and you need to drink a full glass of water. You cannot lie down for 30 to 60 minutes afterwards. There are high rates of GI side effects like esophageal irritation and nausea. And in reality, there is poor real-world adherence and persistence, and this is a major problem. How long should someone take bisphosphonates, and what is that concept of a drug holiday? This is where many patients and providers get confused because the answer is not a simple number. It depends on which drug is used, which route, and most importantly, on the individual patient's ongoing fracture risk. So for the oral bisphosphonates like alendronate, guidelines generally suggest reassessing after 5 years. For IV zoledronate, reassessment comes earlier, after just 3 years, and that's because it's more potent, it accumulates more effectively in the bone, so it provides more durable protection with less doses. For low to moderate risk patients whose T-score has improved and who have no history of hip or spinal fracture, a drug holiday of 2 to 3 years is reasonable. The bisphosphonate that remains embedded in their bone continues to provide some protection during that period, during the holiday. For high-risk patients, those with prior vertebral or hip fractures, very low T-scores, or who are on ongoing AI therapy and have continued bone loss, a holiday is often not appropriate. They should continue treatment or transition to a different agent. Per current guidelines, bisphosphonates should not be continued beyond 10 years for oral preparations or 6 years for the IV zoledronate without a careful individual risk-benefit reassessment. Beyond those timeframes, the risk of atypical femur fracture, while still rare, begins to rise meaningfully, and the incremental fracture prevention benefit decreases. During any drug holiday, bone mineral density should be monitored yearly and bone turnover markers checked as well. If there is a significant bone mineral density loss during the holiday, treatment should be restarted immediately. Fractures have been observed as early as 12 months into a drug holiday in high-risk patients, so this is not a set and forget situation. Now, there are 3 important situations where bisphosphonates are used not as primary therapy, but as essential sequential or consolidation treatment. First, after denosumab is stopped. This is non-negotiable and is covered in detail in the denosumab segment. Briefly, when denosumab is discontinued, bone resorption rebounds rapidly and severely. A bisphosphonate must be started within 6 months of the last denosumab injection to prevent this rebound. This is not a drug holiday from bisphosphonates. This is a mandatory rescue. Second, after teriparatide is stopped. Teriparatide is an anabolic drug that builds bone, and we'll discuss that shortly too. But here is the critical problem. When teriparatide is stopped, the bone that it built will be rapidly lost unless an antiresorptive agent is immediately started to consolidate those gains. Bisphosphonates are the standard consolidation choice. Without them, the benefits of teriparatide treatment largely disappear within months. Third, after romosozumab is stopped. The same principle applies. Romosozumab builds bone through a dual mechanism, but its effects are self-limited to 12 months of treatment, and the gains must be locked in with a bisphosphonate or denosumab immediately after the course ends. The practical message is this: bisphosphonates are not just a starting medication that you take for a while and you forget about it. They are a cornerstone of bone medicine that appears at multiple points in a patient's treatment journey, as primary therapy, as a drug holiday that may be restarted, and as consolidation after every anabolic or rebound-prone drug that comes before them. Now let's talk about denosumab, also known as Prolia. How does it work? Denosumab is a human monoclonal antibody. It's an engineered protein that targets a specific molecule. It's called RANKL or rank ligand. It's receptor activator of nuclear factor kappa B ligand. So RANKL is like an activation signal that tells the osteoclasts to form and function. So if you block RANKL, denosumab prevents the osteoclasts from maturing and working. So the demolition crew never gets its marching orders. The dosing is 60 milligrams subcutaneous injection every 6 months, typically given at a clinic or by a healthcare provider. And what are the advantages? It is highly effective. In meta-analysis, denosumab shows the largest bone mineral density gains of any antiresorptive in this setting. It reduces fracture risk by approximately 50% compared to placebo in some studies. Administration is quite easy. It's just twice a year injection, and it works well in patients who have kidney issues, unlike the bisphosphonates, which require caution in renal insufficiency. The disadvantage is called the rebound effect, and this is critical. This is arguably the most important thing to know about denosumab or Prolia. When you stop denosumab without transitioning to another drug, there is a rapid rebound in bone resorption. The demolition crew comes back with a vengeance. Bone turnover markers spike, bone mineral density drops rapidly, and patients face a significantly elevated risk of multiple vertebral fractures, sometimes within just months of stopping. This is not a rare occurrence. This is predictable pharmacological consequence. The rule is denosumab should never be stopped abruptly without a plan. Within 6 months of the last denosumab dose, patients must transition to either IV zoledronate or an oral bisphosphonate for at least 12 months with bone turnover marker monitoring to confirm suppression. Does denosumab have anti-cancer benefits? No. Unlike the bisphosphonates, denosumab has not been shown to reduce breast cancer recurrence or mortality. The ABCSG18 trial suggested there might be a small benefit, but a larger trial did not confirm it. Current guidelines do not recommend denosumab for recurrence prevention of breast cancer. What about romosozumab? Romosozumab, brand name is Evenity, is a newer class of drug. It's a monoclonal antibody that blocks a protein called sclerostin, which normally inhibits bone formation. So by blocking sclerostin, romosozumab both increases bone formation and decreases bone resorption simultaneously. It has a dual action that no other bone drug has. It's given monthly as a subcutaneous injection for 12 months only. Who is a candidate for romosozumab? It's approved for postmenopausal women who have severe osteoporosis and are at a very high risk of fracture, typically those who already had a fracture or who failed other therapies. It is not currently indicated as first line for AI-associated bone loss. There's a critical caution here. Romosozumab carries a black box warning for cardiovascular risk, specifically increased risk of heart attacks and stroke. It should not be used in patients who have had a heart attack or a stroke within the past year. After the 12-month course, it must be followed by antiresorptive therapy to maintain gains. Everything we have discussed so far, the bisphosphonates and denosumab, works by slowing bone breakdown. They are antiresorptive. So is romosozumab. They reduce the activity of the demolition crew, and that is valuable, but it has limits. You can't build a stronger building simply by slowing demolition. Sometimes you need to also accelerate construction, and that is exactly what the anabolic bone drugs do. Instead of suppressing osteoclasts, they directly stimulate osteoblasts, the bone building cells, to lay down new bone. For patients with very severe osteoporosis who have already had a fracture or who are at very high risk of imminent fracture, anabolic therapy can achieve bone mineral density gains that the antiresorptive drugs simply cannot. There are currently 3 approved anabolic drugs. Romosozumab, which we talked, is antiresorptive as well, which we just covered. Again, romosozumab works by blocking sclerostin to simultaneously build bone and reduce the resorption. The other 2 are PTH-based agents that work through a completely different mechanism, and those are what we are going to focus on right now. The teriparatide, brand name is Forteo, is a synthetic version of the first 34 amino acids of the human parathyroid hormone, or PTH, which is the active portion of the molecule. It's given as a daily subcutaneous self-injection of 20 micrograms. Now, here is the fascinating pharmacological paradox. Parathyroid hormone at continuously elevated levels, as seen in hyperparathyroidism, actually causes bone loss. But when it's given in small, intermittent daily pulses, the same hormone drives bone formation more than bone resorption. The brief daily spike in PTH activates the osteoblasts through a signaling cascade that is genuinely net anabolic. Teriparatide primarily builds trabecular bone, the spongy inner architecture, which is the type of bone most commonly involved in vertebral fractures. Abaloparatide, brand name Timlis, is a synthetic analog of parathyroid hormone related protein, or PTHRP, not PTH itself, though it does act on the same receptor. It was specifically engineered to be more anabolic and less calcium mobilizing than teriparatide, meaning a lower risk of high calcium in the blood or hypercalcemia. It's also given as a daily 80 microgram subcutaneous self-injection. Clinical trials show that abaloparatide produces bone mineral density gains similar to or slightly greater than teriparatide and may have a somewhat faster onset of anti-fracture benefit. Important limitations of these two anabolic drugs, teriparatide and abaloparatide, we just talked about. They are approved for postmenopausal women with osteoporosis at a high risk of fracture, meaning prior vertebral or hip fractures, or T scores at or below -2.5 with additional risk factors. They are not currently first line for AI-associated bone loss, which is managed with the antiresorptive drugs we talked about. However, for the subset of women on AIs who already had fractures or who have failed the antiresorptive therapy, teriparatide or abaloparatide may be appropriate. Both carry a maximum lifetime cumulative use of 2 years total, meaning teriparatide and abaloparatide together cannot exceed 2 years over a patient's lifetime. And that's because of a theoretical risk for osteosarcoma. And that was identified in animal studies. Very high doses were given for the full lifespan of these animals. It has not been confirmed in humans. And the FDA has removed the black box warning that previously accompanied teriparatide. But the 2-year lifetime limit remains on the prescribing information. And critically, as noted in the bisphosphonate segment, both teriparatide and abaloparatide must be followed immediately by an antiresorptive agent when they are stopped. Without consolidation therapy, the bone gains will be rapidly reversed. A bisphosphonate is the standard consolidation choice after teriparatide. After abaloparatide, you can use both the bisphosphonates and denosumab. In the overall treatment sequence for severe osteoporosis, the emerging thinking is as follows. Anabolic drug first to build bone, then the antiresorptive to consolidate and maintain those gains. This sequence produces greater long-term bone mineral density than starting with antiresorptives alone, especially in patients who are at very high imminent fracture risk. Before we close this episode, there is one more important category of bone protection that belongs in any complete discussion, and one that is often left out of the osteoporosis conversation entirely, and that is menopausal hormone therapy, or MHT, specifically body identical estradiol and the emerging role of testosterone. We established in episode 1 that estrogen is the primary regulator of bone remodeling. When estrogen drops at menopause, the osteoclasts, the demolition crew, become hyperactive and bone loss accelerates. It follows logically that replacing estrogen should protect the bone, and the evidence confirms exactly that. MHT with estradiol is an antiresorptive treatment. It works by restoring estrogen's natural suppressive effect on the osteoclast activity, essentially the same biological mechanism that kept bones healthy during our reproductive years. Unlike bisphosphonates, which enter osteoclasts and cause their death, estradiol works upstream by modulating the entire RANKL OPG signaling axis in a physiological way. Unlike denosumab, which blocks one specific molecular signal, estradiol restores the hormonal environment that bone remodeling evolved to require. It also increases type 1 collagen production and osteoblast survival, meaning it has mild bone building properties in addition to its antiresorptive action. The result is a restoration of the balance between resorption and formation that menopause has disrupted. What the evidence shows. MHT significantly reduces osteoporotic fractures. The Women's Health Initiative found 6 fewer hip fractures and 6 fewer vertebral fractures per 10,000 women per year compared to placebo. A meta-analysis of 2 years of oral MHT showed that lumbar spine bone mineral density increased by 6.8% and femoral bone mineral density by 4.1% compared to controls. Women under 60 with MHT had 45% lower risk of total fractures, a risk reduction that rivals or exceeds that of standard dose bisphosphonates in this age group. Even very low doses are protective. Oral micronized estradiol at just 0.25 milligrams per day for 3 years produced significant bone mineral density gains at the hip, the spine, and total body compared to placebo, with bone turnover markers reduced to a degree comparable to the standard 1 milligram dose. A word about timing. MHT is most effective for bone and most favorable overall risk-benefit when it is started in the perimenopause or the early postmenopause period within the first 10 years of that menopause transition. This is also when bone loss is the fastest and intervention has the greatest impact. The evidence does not support a rigid age cutoff for women already on MHT. Continuation is still appropriate, and it should be individualized based on the woman's symptoms, preferences, risk factors, and ongoing clinical assessment. Every woman's situation is different, and a blanket rule about stopping at age 60 does not reflect the current evidence, especially for body identical hormones. Body identical versus synthetic hormones. There's an important distinction here. Body identical hormones are also called bioidentical hormones. They have the exact same molecular structure as the hormones produced by the human body. The most commonly used are at 17-beta estradiol, which is the same molecule as human estradiol, and also micronized progesterone, which is identical to human progesterone. These are available as FDA-approved pharmaceutical products in standardized doses or by compounding pharmacies, patches, gels, sprays, oral tablets, and also vaginal formulations. Body-identical estradiol and micronized progesterone have a more favorable safety profile than older synthetic formulations. The VTE or clotting risk and cardiovascular concerns associated with older hormone therapy data came primarily from oral conjugated equine estrogens, which are derived from the horse's urine, combined with synthetic progestins like medroxyprogesterone acetate. These are structurally different from human hormones, and they have different metabolic and vascular effects. The evidence for body-identical estradiol is quite different. What about the routes of administration and the doses? So transdermal estradiol in the forms of patches, gels, sprays, and emulsions is generally considered the preferred route for bone protection and overall safety because it bypasses first-pass liver metabolism entirely. By avoiding the liver, transdermal estradiol does not activate the coagulation pathways that have been associated with clotting risk from the oral synthetic estrogens. Multiple studies confirm that transdermal estradiol does not increase VTE or clotting risk even in women who have thrombophilia, obesity, or other VTE risk factors, which is a finding that has led to significant evolution in prescribing practice. Patch doses range from 14 micrograms per day, which provides some bone protection, up to 100 micrograms per day. Standard bone protective doses are 25, 37.5, 50, 75, and 100 micrograms per day. Standard doses of 1 milligram produce mean serum estradiol levels of about 65 picograms per ml, and 2 milligram produces about 108 picograms per ml. The VT concern with oral estrogen is most clearly linked to the combination of oral synthetic estrogens with synthetic progestins, not to oral micronized estradiol alone or combined with micronized progesterone. A 2025 systematic review confirmed that oral estrogen alone has a much safer VTE profile than oral estrogen combined with a synthetic progestogen, and that the type of progestogen is a critical determinant of risk. When oral estradiol is used with micronized progesterone rather than a synthetic progestin, the risk profile is substantially improved. So, what serum estradiol level is associated with bone protection? Research converges on approximately 60 picograms per ml as the minimum threshold for meaningful suppression of bone resorption in most postmenopausal women. Women with circulating estradiol between 60 and 90 picograms per ml show significant reduction in bone resorption markers, and levels above 90 picograms per ml do not appear to provide additional bone benefit. That being said, current evidence-based practice does not recommend routinely monitoring serum estradiol levels to guide MHT dosing. The standard approach is to dose based on symptom control and clinical response. Checking levels can be useful when absorption or adherence is in question or when clinical response is unexpected. If the levels are checked, mass spectrometry is more accurate than immunoassay, particularly for the transdermal estradiol. The progestogen question. Any woman with an intact uterus taking systemic estrogen of any sort must also take a progestogen or progesterone to protect the uterine lining from endometrial hyperplasia and cancer. Micronized progesterone, identical to human progesterone in molecular structure, is the preferred option. It does not interfere with estradiol's bone protective effects. It has the most favorable breast cancer and cardiovascular safety profile of any available progestogen, and it does not carry the VTE risk associated with synthetic progestins. Women who have had a hysterectomy can take estradiol alone without progesterone. Testosterone and bone. So the emerging picture. Testosterone is not exclusively a male hormone. It is also produced in women by the ovaries and the adrenal glands, and it declines with age and accelerates with surgical menopause. It acts directly on the bone through androgen receptors, as well as indirectly through its aromatization to estradiol, meaning it converts to estradiol. Multiple observational studies have found a positive association between testosterone levels and bone mineral density at the hip and at the lumbar spine in postmenopausal women, with some data suggesting that women with testosterone levels below 30 nanograms per deciliter have meaningfully lower bone mineral density. A landmark study by Davis and colleagues showed that adding testosterone to estradiol therapy significantly enhanced bone mineral density gains compared to just estradiol alone. There is also evidence that higher testosterone correlates with slower bone loss in older postmenopausal women over 65, independent of estradiol levels, which is particularly relevant given that cortical bone loss, that's the predominant type of bone loss in older women, may be more androgen sensitive than trabecular bone loss. However, The evidence base for testosterone in bone is not yet at the level where it is recommended by societies as a primary bone treatment. Clinical trials specifically designed to assess fracture outcomes with testosterone therapy in women are still lacking. What the evidence does support is that testosterone deficiency, particularly after surgical menopause or bilateral oophorectomy, or removal of the ovaries, may contribute to bone loss that estradiol alone does not fully address, and that testosterone replacement in this context is physiologically rational and increasingly supported by data that's emerging. Currently, the primary approved clinical indication for testosterone in postmenopausal women is what we call hypoactive sexual desire disorder. And this needs to change, though its bone effects make it an area of active research interest. Women who have undergone bilateral ovary removal or oophorectomy are already on estradiol therapy may have particular reason to discuss testosterone with their provider. The critical limitation for women on aromatase inhibitors. So, MHT is generally contraindicated in hormone receptor positive breast cancer, which is precisely the population of women on aromatase inhibitors. And this is why MHT is not part of the AI management algorithm. But for the broader postmenopausal population, women without hormone sensitive cancer, body identical MHT is a clinically appropriate, evidence based, and physiologically rational option for bone protection, especially in the perimenopause and early postmenopause phases. For women with premature ovarian insufficiency or surgical menopause before age 40, MHT is not optional, it is essential. The bone loss from decades of estrogen deficiency starting before age 40 is profound and cumulative. These women should be on MHT until at least the average age of natural menopause, approximately 51, and should have testosterone levels assessed, especially after bilateral oophorectomy, as combined replacement may provide superior bone protection. So here is a quick rundown of what we talked about in this video. Menopausal hormone therapy with body identical estradiol is a physiological, antiresorptive, and mild anabolic option for eligible postmenopausal women without hormone-sensitive cancer. It restores the hormonal environment that bone remodeling requires. It reduces fracture risk and is most effective when started early in the menopause transition. Transdermal estradiol seems to be the preferred route for many women. Oral micronized estradiol combined with micronized progesterone is also very much appropriate. The serum estradiol level associated with bone protection is approximately 60 picograms per ml. Even though current guidance prefers to follow symptoms and clinical response rather than blood levels, hopefully that will change. Testosterone may provide additional bone benefit, especially after surgical menopause, and it is an area of growing evidence. It is still contraindicated in hormone receptor positive breast cancer per current guidance. Bisphosphonates suppress osteoclasts via the mevalonate pathway. They stay in the bone for up to 10 years. They serve as primary therapy, post-holiday restart therapy, and mandatory consolidation after denosumab, teriparatide, and abaloparatide, and romosozumab. IV zoledronate also has proven anti-cancer benefit in postmenopausal women with breast cancer. Denosumab blocks the RANKL signal we talked about and produces the largest bone mineral gains of any antiresorptive drug, but it must never be stopped without an immediate bisphosphonate transition plan. The rebound fracture risk is real and predictable. Teriparatide and abaloparatide are PTH-based anabolic drugs that build new bone, the strongest tools available for severe osteoporosis. Both have a 2-year lifetime limit and must always be followed immediately by an antiresorptive drug to consolidate the gains. Romosozumab blocks sclerostin to simultaneously build bone and reduce resorption over 12 months, but it carries a cardiovascular black box warning and must be followed by antiresorptive therapy. All bone medications require adequate calcium and vitamin D before starting, with blood levels checked, not assumed. In the next episode, we will discuss the side effects you need to know about, specifically hypocalcemia, osteonecrosis of the jaw, atypical fractures, and the specific side effects of the anabolic drugs. See you in the next video.